join me in welcoming back to Forsyth County, Dr. Elizabeth Woodcock.
Thank you so much, and I love it. Nobody says positive news or I don't have a good joke, although I was like, oh my gosh, I don't know if I would have come today if I had gotten pulled over. So thanks so much, y'all, for having me. I really appreciate it. I wanted to let y'all know that if you are interested in double APC, if any of you are coders and you would like the certificate for this hour, please do send me an email. I'll give you that information afterwards, and I'd be delighted to send you the certificate. As Laura had mentioned, I am here to talk about the realities of the landscape for this year and likely into 2026. We're at about 80 days into 2025, and I've been fortunate enough to study the language of reimbursement since the early 1990s. Some of you may remember we used to submit a claim with a charge and we got paid a percentage of it. It was beautiful. Our meetings about the upcoming fee schedule for the year lasted about 2.5 minutes. We would all sit around and be like, oh, well, let's charge a little bit more. And everybody was like, okay, that sounds good, because we would get paid a little bit more. And so, of course, the tides reversed very quickly in the mid-1990s, and now our scale is really based on the CPT codes that we submit and indeed the reimbursement that we get for those codes. And so we want to spend a few minutes talking a little bit about kind of what's going on at the federal level. I'll touch a little bit about what's going on at the state level and how that will impact basically your bottom line. We're going to focus this morning on the professional side of reimbursement. So this would be physicians, APPs, advanced practice providers, nurse practitioners, physician assistants. We're not going to talk about the facility side, so like the inpatient, prospective payment system. I can certainly answer a little bit of questions about that, but we're diving deep into the practice management side. A lot of changes going on in the last, really the last 6 months, and we're feeling those now, and we have more on the horizon. As we all know, we are not a single payer system in the United States. We have multiple insurance companies, although there's less and less every day. It used to be that we had several dozen. Now we have, they're pretty consolidated, United, Cigna, Anthem, etc. Not a ton, but we don't have the same payers. And so we're going to spend a fair amount of time talking about Medicare, which of course is our federal government's payer. And we consider that to really be the bellwether of reimbursement. But it's very important to recognize that it is not the only payer. So when I talk about this is what Medicare is going to do, that doesn't necessarily mean that that is what United Healthcare is going to do. So I just wanted to give that little bit of caveat before we get started. Telemedicine has been on the news in the last week, and so we want to kind of update where we are on telemedicine, and then we're going to dive into reimbursement for Medicare and some new Medicare services. Interestingly enough, we also just found out last week that there were some changes. So really think about this program as kind of level setting. You know, you're hard at work, you're seeing patients. We are overwhelmed with demand. I mean, let's stop and just say that and recognize there are so many patients to see. So we're experiencing that all across the country. Supply and demand are out of balance. We know there's a ton of patients. So you're in your practices, you're in your offices, you're working super hard. And so this program is to really say, well, what is going on in Washington, D.C. and Atlanta that will be affecting those remittances that come in for all of the services that I'm offering? And then we're going to talk a little bit about the CPT coding changes that came about for this year. And I want to spend a few minutes talking about the future.
because I don't have a crystal ball, but there's a lot of stuff going on in healthcare. So I want to spend a few minutes kind of reflecting on that. Most importantly, when you walk back and you go back to your offices and tell your physician something and they say, what are you even talking about? And you say, well, yeah, I heard, this crazy lady this morning, I heard at this program, she was telling me about this, and they're like, oh, no way, that's not true. So what I have done is given you evidence. Physicians are scientists. I happen to have been married to one for 30 years. And believe you me, when we go into this stuff, he's like, are you crazy? I'm like, let me tell you, let me show you the document. I'll run over the Federal Register. So you will find in these slides, on every single slide, with the exception of about 3, there is indeed the source of the information. So if you hear something that's really, really interesting and your physicians ask about it, you can go and actually find not just my slide, but the real truth, the story. So indeed, we know that prior to the pandemic, I used to stand up here and go, telemedicine, people would be like, oh, what is that? That happens in Taiwan, who does that? And you're right, because less than 0.5% of Medicare claims were from telemedicine. And I get it, because the rules prior to the pandemic were so restrictive. The patient couldn't be in their home. Hello, well, where were they? Well, you could drive them over to a critical access hospital or maybe put them in an ambulance, and if they had the equipment and they could transmit the images to, are you crazy? Nobody did this stuff. And so during the pandemic, as we all remember, within literally weeks, we were all like, telemedicine? Oh yeah, we're in. We got to do it, right? Because we had stay-at-home orders, et cetera, et cetera. So what happened is the government couldn't pivot that fast because there was a law in place that they weren't allowed to pay for telemedicine services. But they pivoted very, very quickly with a bunch of orders and exceptions, and something called the Public Health Emergency, or PHE, allowed them to make those exceptions. It would sort of be like if all of a sudden Forsyth County said, well, you know what, we don't really like the speed limits on 75 or 400 when it's coming through our county, so temporarily we're going to make them be 90 miles an hour, or we're going to temporarily lift the seatbelt law. So they couldn't do it forever. So indeed, come about, and after the public health emergency, we're like, okay, the pandemic's over. So telemedicine was over too. And in fact, the waivers were up on December 31st, 2024. So we knew that, well, we can't really do this stuff anymore. So within a matter of weeks before this was all over, the president signed the American Relief Act, and that extended telemedicine, ironically, through next week. So March 31st, 2025, telemedicine was over. We'll talk about what we were hoping that American Relief Act will do, but unfortunately did not address. Now, what we do know is that telemedicine, even beyond this March 31st date, was going to allow a few different things, right? So teaching physicians could do their thing. We know that physicians would be able to use their enrolled practice locations. So for example, if you have a physician who works out of their house now to do some telemedicine visits, there was kind of like a sticky issue. Well, did they have to put that address on the claim or not? Nope, we could stick with our practice. We also know that the states kind of came in, and interestingly enough, despite being backwards on many, many things related to healthcare, in Georgia, we are actually one of the most sort of cited as one of the best states to practice at for telemedicine. Isn't that interesting? And so I've actually given you a link. It's about a 40-page document to all of the laws related to telemedicine, including actually getting paid for Medicaid patients via telemedicine. So most importantly, in Georgia, we have what's called a parity law, which means that we actually have insurers who practice in the state have to pay us the same amount as seeing the patient in person. So we actually have really, really favorable laws for telemedicine. Now, let me take a few minutes break for telemedicine, but it's related because you can do this via telemedicine to tell you about some pretty exciting codes, particularly if you're in primary care or if you're in a medical specialty. Neurology comes to mind immediately, that you work with a lot of caregivers. Now, this is something that forever we have not been paid for. Think about the spouse or maybe a parent who's in the room that is going to take care of the patient. And so your physician or APP is treating the patient, but also importantly educating that caregiver to take care of that patient at home, because we don't want them back in the ED or in the inpatient setting. So we never really got paid for that. And starting January 1st, 2025, we can, including for Medicare. So there are CPT codes you can see, even for group training. Again, that is for caregivers, so a spouse, etc. These are really favorable, and we can do them by telemedicine, which is why I added them to this section. So please, please make sure if you do any sort of caregiver education that you take note of the fact that these are actually billable and payable codes. We also know that our virtual check-ins are payable now. We have what I like to call a real CPT code. And the reason I say that is our G codes are for Medicare. So we now have a real CPT code 98016. And this is a virtual check-in. And for those of you in the back of the room who may not be able to read this because it's small, basically it's kind of like a touch base with the patient, brief. If you did not see the patient in the last week or are planning to see the patient in the next 24 hours. And one of the reasons I like this code is, y'all remember the whole thing about electronic health records and on-chit, and we used to get paid, well, it was actually up to $64,000 per physician to get an electronic medical record. So this, I'm going back about 10 years. Remember, we used to, it was a pretty big thing. Now, during that EMR conversion, when all of us were getting electronified and we were getting paid to do so, we had to have a portal. And I don't know about y'all, but we didn't really know what to do with those portals. Remember the whole meaningful use? And you were like, what do I do with the portal? Well, now I wish I could sock that portal back into whichever vendor gave it to me, because patients love the portal. Now, I have to say, we kind of did this to ourselves. Remember, we would sit in the waiting room and we would teach our patients how to use the portal because we needed to do that for meaningful use. Now, our patients are really used to messaging us, and we don't have a good mechanism of getting paid. So if you haven't explored this already, it is time. Please know that there are multiple CPT codes for secure messages from patients, including this one that is payable for Medicare. So again, 98016. Now, it's a little bit confusing because the American Medical Association, the AMA, which of course is the professional association that physicians are part of, many physicians, not all, the AMA is the one who issues CPT codes. I'm not really sure why, right? That's just the history of the American Medical Association kind of took that upon themselves in about the 1970s. And you think, why do we even have CPT codes? Well, the reason we have CPT codes is physicians would write down, saw the patient, treated the patient, gave the patient some prescriptions or medications. And the insurance companies would look at that 3 sentences and say, how do I pay that? I don't even know. That's why we have CPT codes, because it's codifying the physician's work. And so the AMA gives out these CPT codes. They make changes every year. But they actually added CPT codes for telemedicine visits. So the CPT codes that they added are aligned, as you can see, with office-based evaluation and management codes, I won't go into these in depth other than to note if you are doing telemedicine is to please know about these codes. Now hold on, Elizabeth, because you just told us telemedicine is going away March 31st, right? So we only have a couple of weeks, not even 11 days. Oh no, just last week when Congress passed the Balanced Budget Act, you may have heard about it, avoiding the government shutdown, there were two pieces of important healthcare legislation that were put into the Balanced Budget Act that was subsequently signed by the president on March 15th. So we're only a week out from the signature. The two important pieces of healthcare legislation, number one, is telemedicine was extended through September 30th of this year. I'm a little bit wary about this because I'm like, okay, well, this is a whole line of business. It's a lot of work. You don't just do telemedicine on Tuesday and say, well, I did it. Like, you got to figure out how to schedule it. Where's the computer going to be? Who's going to room the patient? I've got to train a medical assistant to do virtual rooming. This is not easy, right? And so it's really confusing to keep having, okay, well, thank God I have it for another 6 months. So I want to say that I feel you. I know this is difficult if you're continuing to do this work. However, advocates have really pushed to keep this added, and we now have it until the fall. The second thing that was left in the healthcare docket for the Balanced Budget Act was hospital at home services. So this is something we're seeing some, particularly hospitalists, internal medicine physicians get involved in. A little bit debatable as to whether or not it was going to be an extended, and it was. And so this is important because this signals what the federal government is interested in. So again, telemedicine and hospital at home. As you'll learn about in just a few minutes, the other component of healthcare administration that we were desperately hoping the government would include last week did not come in. And indeed, this is what we were hoping they would address. So we do know, per the announcement in early November of 2024, that physicians, remember we were talking about the professional fee services, so this is physicians and APPs, we're actually receiving about a 2.83% decline. Not even about. You are getting paid today 2.83% less for the services that you perform in 2025 as compared to the services that you performed in 2024. So basically the whole scale dropped. Now you might say, hey Elizabeth, I remember you're telling me about Medicare, and I don't even really see that many Medicare patients. So the challenge here is that the 2.83% applied to Medicare is applied to the resource-based relative value scale. And that is the scale that Medicare uses, and they kind of keep up with that scale. The challenge for us as medical practices is it is also the scale that United, Cigna, Aetna, and many of the commercial payers use. So even though we're not a single payer system, this 2.83% for any insurance company that is actually paying based on the scale that Medicare uses, unfortunately, this is indeed applied to us. Our hospitals did not receive the same amount of reimbursement cuts, and nor, interestingly, did our community health centers. So community health centers are generally FQHCs, federally qualified health centers, and rural health clinics, or RHCs. They're actually paid on a different reimbursement schedule than the PFS, and it's actually pretty favorable. So this is an interesting trend as well, is that we're seeing more and more hospitals and health systems in the United States realize, hey, my medical practices, I have seen decreased reimbursement for the last 20 plus years, including, hello, we were just in the pandemic. And the group of physicians in the United States, all of them that stepped up and did all of this work, this is what you're doing to us? 3% decline? I mean, what's the future going to hold? So we're looking for more creative ways, and this is one of them. So don't be surprised if you see, wow, somebody's opening up an RHC near me, because counties like you are in are actually ripe for all of the elements of being able to open these rural health clinics. And you can see the reimbursement, which is now at about 150% of a private medical practice. Again, that's 1.5 times as much as you get paid. It's not going to be a surprise that more and more are looking at that particular model. The American Medical Association estimates that since 2001, physicians have actually gotten paid almost 30% less for the same services. So as you know, right, it's getting more and more expensive to pay for medical assistants and nurses, and yet once again this year, we've seen the decline on the physician fee schedule side. We were hoping, and there were multiple pieces of legislation, including one that was included, but unfortunately got dropped before the law was signed last week. And so we were just desperately, well, hopefully somebody will come in and save physician reimbursement, but they did not. So I'm putting up, that's a big no-can-do crackerjack. So our last hope was last week, and we're going to have to live with that 2.83%. In addition to the 2.83%, several of our specialties had a little bit of change to the CPT codes they normally use. Interestingly enough, psychologists and social workers who are not normally MDs or DOs actually do receive a little bit of an increase. So this is good. If you are a psychiatry practice, for example, and have psychologists, or maybe primary care and you have behavioral health components, on the physician side, we did see for the 5th year in a row a decrease to IR and vascular surgery, who share a lot of the same CPT codes. And indeed, we also saw a decrease for ophthalmology. Ophthalmology, of course, sees a lot of Medicare patients, so this was a really crushing blow to that specialty. So in addition to the 2.83% decline, ophthalmology is seeing another 2% decrease based on the CPT codes that they use. This is a super tiny chart, and indeed will be in your handouts. But the big message here is basically no other specialty got more than a minus to a plus 1%. So very, very little movement in the fee schedule this year, which was a good thing for us, right? So endocrinology, dermatology, neurology, rheumatology, urology. So we saw very, very little change beyond that 2.83%. So here's the rest of the specialties. Again, I mentioned vascular -2, and the only other one on this kind of bottom alpha list is thoracic at a -1%. So these are the estimates that CMS, the Centers for Medicare and Medicaid Services, are using for this year, 2025, for those specialties. Y'all might remember that pesky little thing called sequestration. This actually goes back to more than 10 years ago, and we were so excited because 2025 was actually the end of sequestration. And if you look at your remittances in your business office, and if you don't, make a note of that to do that, because I actually find that remittances, or you can pull down electronic reports, because most of them are coming in electronically, they're like a treasure chest of information. It is amazing what you can find. You know, wow, I didn't know I was getting denied for this, or I'm not getting paid for this. And of course, on the PFS side, professional fee schedule, we actually get paid on a line item basis. And so if you look at your remittances, you can actually see, oh, I might be getting paid for this E&M, but I'm not getting paid for this additional service I'm providing to patients. And then it's up to you to decide, okay, if I'm not getting paid for this, should I be doing it? Do I actually continue to perform the service? Or is there something else I can do from a business perspective? So back to our sequestration, which is reducing all payments from Medicare by 2%, and you'll see those on your remittances with the SARC code, which is a claim adjustment reason code, and that is CO 253. CO stands for contractual obligation. So basically they're telling you, you are contractually obligated to not get this money. Now, I'm a billing person by background. CO doesn't always mean I'm contractually obligated. Where's the contract, people? I want to see it in writing. So this is something that, from a billing perspective, looking at your remittances and really being able to determine, hey, is this something I should be getting denied? The government has indeed taken down any payment from the government. This is on the hospital side as well as the physician side by 2%. And because they gave us a little bit of a stay of execution during the pandemic, they extended sequestration through 2030. So we thought we were going to be up with it in 2025, but no luck because of the pandemic. You might say, well, gosh, Elizabeth, how can I know this is impacting me? I love to use the PFS calculator. You can actually type in the CPT codes that you use, and it will come back to you as to what Medicare will pay. Now, there are two different sections of Georgia, and we actually do get paid two different ways in Georgia, depending on where you are. There's Atlanta and the rest of Georgia. I love that. That is a true story. You can look it up. Atlanta and the rest of Georgia. So there are two different payment rates depending on your CPT code of your practice location. And they do vary by about 5%. If you really want to make the big bucks though, go up Dalton and cross the line into Tennessee. And indeed that Chattanooga area actually gets paid more than us in the rest of Georgia. So we saw some other changes for Medicare services. We're seeing payments for psychologists and social workers is a really big deal. This is interesting, FDA cleared digital treatment devices for mental health. So this should be very interesting for us in the commercial market to see. Basically, we can now get paid for the patient having a device, you know, kind of like what is that company, Noom or Loom, like that is, you know, mindfulness app. So basically getting paid for helping, supporting patients with a mental health app. Safety planning interventions, and then post-ED discharge. Basically, these are payments for mental health in the US that we have not seen before. Now, speaking of preventive services, including mental health, this is one of my favorite kind of tiles within the CMS website. So this is actually going to show you what services Medicare pays for on a preventive basis. So it's everything from diabetes education, I mean, all of it, all in one place. It'll give you the CPT codes as well as the frequency so that you can tell, okay, I can do smoking cessation for a patient X amount of times per year and get paid for that. So really awesome little chart. It also gives you everything with the T is you can do that by telemedicine and get paid for the same as in person. Watch though for the time that is involved with these preventive services. So a couple of changes got made. One is I can do a arteriosclerotic cardiovascular disease risk assessment service. So this is basically a very, very long term for, I can do a screening on patients when they come in and I can get paid for that. And you might even ask, well, what kind of screening? Well, the American College of Cardiology actually gives you a screening tool that you can use. So there is no dictated screening tool, but you can find some. If you are not yet using screening tools and billing for them, I'm again going to encourage you to walk out here and to start using them. And I say that because for those practices that are still relying on 99213s and 99214s only, and you're performing all these other services, you're messaging your patients, you're teaching your caregivers, you're giving your patients screening but verbally by having your nurses or MAs do this, it is time for you to open up these reimbursement books and to say, what else can I get paid for? What else can I get paid for? Because you deserve to be getting paid for the services that you render. So we do know there were some changes to colorectal cancer screening as well as Hep V vaccinations. So the one code I really want to stick with you today too is G2211. This is a code where you can get paid basically about $20 extra per E&M visit. I love this code, and CMS has said now for the second year in a row, no one is using it. And I am terrified they're going to take it away. What can it be used for? It can be used by physicians who are the focal point of the relationship with the patient. It doesn't necessarily need to be a primary care provider, although often it is, but actually in part of the vignettes that CMS uses, it is an ID physician, infectious disease physician, who's working with the patient to make sure they continue to take their medications. So indeed, 2211, this kind of makes up for all of those cuts that we're seeing. And so please, if you can use this code, start using it. Again, it's about another $20 for every visit. We know in 2025, we can now use them with AWVs for Medicare, and vaccines, as well as Medicare preventive visits. So a lot more scope on G2211. Speaking of ID or infectious disease, we also know that the infectious disease physicians are now able to get paid a little bit of an additional money for services they perform in the hospital. So this is consults, hospital visits. They can now use a code G04545 for any patient that they see. So it's a really big opportunity for infectious disease. If you happen to be ID, please do make sure you look at the ID Society. I was super excited about this program, Advanced Primary Care Management. A little bit of a throwback to the 2000s where we had this capitation, we got paid per member per month. Well, it was kind of hairy, but it was a reimbursement opportunity. And you can see now, I mean, $15 per month, okay, that's not a ton. But basically the government today is paying an additional $50 per month on top of seeing patients. And then if the patient who doesn't have two chronic conditions, right, for a Medicare patient, in fact, we do know statistically that about 70% of Medicare patients would fall under here. I mean, that's some chunk of change, $110 per month that we can bill in addition to seeing the patient. So you may say, well, Elizabeth, why are you not excited about it anymore? Well, we found out last week, unfortunately, that CMS is actually making a decision to close this program. It just started, and now it's being closed. So as you know, we changed administrations, and this is where part of our challenge is like, you know, putting in all the effort to kind of build this out. I can't recommend it anymore because the program's now been canceled. So there were some questions I would have asked you to take a look at, but I'm not going to because it's not worth the effort to get this for now another, 8 months, because the program is already being canceled at the end of the year. So we haven't seen any changes at all to the quality payment program. You guys might remember this. We sometimes call this MIPS, the Merit-Based Incentive Payment System, because that's one of the components of it. The big news here is we continue to have a -9% right? I already told you about a 2.83% penalty. Now we have a 9% penalty on top of that. We have got to avoid that. Unfortunately, there is no bonuses. We used to have a bonus. Last year it was 1.87%. We got a little bit of extra cash if we participated effectively in this program. It no longer exists, and so what we're doing now is we are simply fighting against the penalty. If you have no idea what I'm talking about, make sure you go on to the main website. It is for any physician or APP that sees it's about $90,000 or more in per year in total Part B charges. So allowed charges. So you do have to have some Medicare business, not a ton, but on the website you can actually type in your physician's NPI and it will tell you whether or not you actually have to comply. Fortunately for us, I don't know if this is fortunate, but every time a hurricane comes through, we actually are exempted from the program. Seems a little crazy, doesn't it? But the government, part of its law is, hey, listen, if there is any sort of natural disaster, if we declare an emergency, then the physicians who are in that area don't have to comply with this program anymore. You might say, well, gosh, but it's 9% of all your Medicare business. So, I mean, it's actually, I mean, I will say it's important to have a hurricane, but it's important to know that indeed, if you have to comply. So you can see that for 2024, we were, if you were in this county that was impacted by Helene, then you do not have to report for the quality payment program. We do know that this year there are about the same number of categories and points. I could talk literally all day about the quality payment program. Happy to answer questions afterwards. But my big message there is please, please do not get penalized. 9%, we cannot afford that. And because it comes 2 years later, that's where a lot of physicians get caught up in that. In fact, I'll just tell you a personal story. My husband hired a physician, his group hired a physician, and found out that the physician had not complied back in 2023. And so all of his remittances to Medicare are now being decreased by 9% because the program follows the NPI. So it's actually a really important thing if you're hiring a physician is to make sure that you confirm they have actually done the quality payment program correctly. Otherwise, they will actually be penalized within your practice by 9%, which is exactly what's happening to my husband's group. So unexpectedly, by the way. See, he didn't listen to me, right? Goodness gracious, he needs to come to this program. So for 2025, we saw about 270 new codes get put on by the American Medical Association. There were some deletions and revisions. And we mentioned those new telemedicine codes. Again, a little bit confusing because we've just been using the E&M codes like 99213, etc. So would ask that you really think about with your payers, Cigna, Humana, etc. What codes are they requiring for telemedicine? Because there's a set of E&M codes that we've been using, the office-based E&Ms, and now there's 16 new telemedicine codes. Which ones should we be using? So all of these got changed. If you are, for example, general reconstructive surgery, you probably already know about these skin graft changes. I really like every year. It's a small investment, it's about $75. I love to get the CPT changes and insider's view. It's just well worth that sort of annual investment, and it gives me the resources for all of the changes for the coming year. And it gives me vignettes, it tells me a little bit about the CPT coding changes. So if you haven't gotten that, and you look at this and you say, ooh, I should probably know about that, I would encourage you to get that book. Super, super good investment. So let's switch now. We got about 6 or 7 minutes. I want to leave some time for questions because I know I've overwhelmed you, not with positive information, but with information. So I wanted to have time to answer some questions. Well, let's spend a few minutes talking about the future. Now, everything I've talked about other than sprinkling in some funny stories is very objective, right? It's kind of realistic. I've given you all the sources. Now I'm going to switch into, hey, what am I hearing? What are the trends? I'm really, really fortunate to work nationally and even internationally now. And so what's going on with our healthcare system? One of the big things that we're seeing is the front door to care is changing. So what I mean by that is patients, it really is kind of that lasting legacy from the pandemic. They became used to turning to their phones, turning to their computers for care. And so you might say, well, not my patients. Well, this is one of those areas where actually everyone is doing this, right? Even us. We don't, we're not diagnosing ourselves. We're probably like, oh, let me Google about this. Let me see about this. And the big trend here is that insurance companies are coming out with virtual first health plans. So what does that mean? Virtual first health plans are starting off with a telemedicine visit. So if you are sick, instead of paying your copayment at a doctor's visit, the insurance company normally for free has a telemedicine appointment to start off, and then they divert you to a doctor's appointment. Of course, we're also seeing more and more interest from companies like Amazon that are really, again, encouraging sort of the change now to the front door for care. We're also seeing companies like Best Buy. They bought a nurse triage center. They actually bought a telemedicine company in England and Great Britain that they now deploy in the US. So the Geek Squad, right, instead of coming over to actually fix your computer, may actually come over to fix you. So more and more companies moving into, not surprisingly, this sort of tech-enabled, space. We're seeing that front door to care increasingly change. The other thing, of course, that happened during the pandemic is that, we didn't see a lot of patients this year. Our ambulatory volumes were very much down in 2020. They picked back up in 2021. During that same period of time, the insurance companies continued to accept premiums. So we all paid our premiums, right? We wanted to be insured, so we kept paying Cigna, United, Humana, etc. And we're like, well, that's kind of funny because we didn't actually see a lot of doctors that year. So what happened is that those insurance companies collected a lot of premiums and didn't have a lot of payouts. So their stock prices, this is Cigna, went up and up and up and up. And not surprisingly, you just think about the financials of that. I collect a ton of money and I don't have to give a lot of money out. And so my stock price is going to keep going up and up. Now it did, there were some kind of decreases here, a little bit of a decrease, and now it's on the upswing again. But the point is that how are they going to sustain that when a zillion patients need to be seen now, right? We're still from the pandemic, all that pent-up demand that's there, the knee replacements, the colonoscopies, they're coming into your offices. So the insurance companies are like, whoa, what am I going to do? Well, this is coming back to bite us because we are seeing claim denials spike big time across the country. So you can see 2024, 66% denials occurring at a higher rate than before the pandemic. Here's the data showing us across the board, denials, right? Medicare, pretty black and white. The rules are there. They're all in writing. Oh, when we get into the commercial space, which includes Medicare Advantage, how do you navigate that? Lots of claim denials, and we're seeing those even increase further. Another thing that we have really not a lot of stops against this, so we're seeing more and more mergers and acquisitions. When I work with health systems, they're like, I think we have 24 hospitals now, maybe 25. I think we're getting a 26. I'm like, what? Right? It used to be like, we'd be like, oh, we got 4 hospitals. This is a big deal. 20 hospital systems, they're in every state in this country. So we're seeing more and more mergers and acquisitions. Health systems are getting larger and larger and larger, and there are no barriers to that whatsoever. So a lot of smaller hospitals are getting swallowed up now. In addition to that, we know for a fact that we have a physician's shortage that is getting worse and worse by the year. And if we look at like Walmart can be like, oh, we don't have eggs on the shelf, right? Anybody run into the egg shortage? I did, right? So we don't have eggs on the shelf. So we gotta go fix that. We gotta get the supply chain going. But probably in the next week or 2, we can figure out how to get more eggs on the shelf. For us, minimum 7 years, right? We got to put people through medical school. We got all this residency that everybody wants to do a fellowship. 7 years is the absolute minimum to get eggs back on our shelves. So we are living with a crisis for the next 10 years. We simply do not have enough physicians. What this will mean is that more and more APPs will roll in. It's just our reality right now in the market. APPs as in advanced practice providers. We do know that the federal administration right now is changing over for Medicare, and indeed we are seeing, as I mentioned before, just last week, the advanced primary care model was announced that it is being taken down. And so as you look at primary care first is another one that's been in place since 2021 that is actually closing at the end of the year. So as you kind of look at and participate in some of these more kind of out-of-the-box models, just be on the lookout to make sure that your investment in time is worth it, because many of these are being deconstructed. Speaking of deconstruction, another thing, of course, that we all know in the news is that the federal government is going through a lot of budget cuts, and that does include federal funding for Medicaid. Georgia now receives $8.6 billion for Medicaid to support the program here in our state, and that money has been announced that it is going away over the next 2 to 3 years. So this is an interesting dilemma for us, of course, as medical practices, because generally speaking, you're gonna see those patients. And so certainly at a hospital, you have to, because of a little law called EMTALA, right? When those patients walk in through, across the threshold of the emergency department, we see those patients. So losing this funding is going to mean that shift between Medicaid and uninsured. And if we think Medicaid is a bad payer, think about your patients. They are our worst payer of all. And so it will continue along the trend that we've seen for the last decade, where more and more financial responsibility will be on the shoulders of our patients, including patients who may have originally been covered by Medicaid, but will be dropped. So we're going to see a lot of changes with Medicaid coverage in the next 2 to 3 years. So what we've gone over is some of the changes that are happening with telemedicine, a little bit about Medicare reimbursement, but remember the impact of that 2.83, which is now set in stone. The 2.83% was hoping for some good news last week. It is going to be impacting not only Medicare, but also any insurer that uses that scale that we talked about. And we talked about some of those programs. The APCM started in January and now will end in December. A little bit about the CPT codes for this year, and a tiny bit about that crystal ball. And now I'd love to turn it to y'all. What do you see that the future holds? Anybody want to start us off? Yeah.
So I actually have a question. You touched on RTM billing a little bit, I saw, and I'm wondering about the PCM piece of that.
Yeah, so the principal care management is that. So we actually are not anticipating any changes with chronic care management, principal care management. There's actually a whole set of transitional care management, all of the CM billing. We're not anticipating changes with that because they sort of fit under the model of preventive care, which is kind of where we think CMS is going. Now I don't have a crystal ball, but I'm kind of giving you my opinion. But based on what we've seen so far, we don't see those changing. What we do see changing in the market is there more and more private equity that is funding companies that are now in the space. And because medical practices can hire those companies and bill for it, we're seeing more and more, a lot of primary care in particular, contract with third-party companies and bill for those services. So I don't anticipate any changes for the CM set of codes. Great question, but again, there's no changes that I see for 2025, but possibly in the future. For those of you who don't know, these TCM, CCM, PCM, all these codes are actually kind of like almost like capitation, right? Because you get paid for a series of services over time, and you do have to have them documented. But it's actually pretty good reimbursement opportunity. Great question. Others? Anybody want to take the crystal ball or have questions? I know I threw a lot of information out at you. Yes, please.
Coming to you with the mic.
What about specialty services that were considered cosmetic? I am from Bariatric Innovations, and pre-COVID we were considered cosmetic. Now we do get a lot of reimbursements because we are considered post-COVID, life-threatening in some cases. Are there going to be any changes in those specialties?
Yeah, I do worry about that because I would keep a very careful watch on that. And I say that because there is so much money being spent in healthcare, and at this point we are just seeing we've got to reduce that money spend, and it is going fast and furious and not perhaps as thoughtful and intentional as some would have hoped. And so I think all of us kind of need to be on the alert to say, like, okay, what are we billing for? What are we getting paid? And how is what's going on? It's important to recognize that just because Medicare does something does not mean that all the private insurance companies will do something, or vice versa. So it certainly will affect Medicaid, but it may not affect United, Aetna, Humana, etc. in terms of how the services that they perform. But I do believe that more and more insurance companies, commercial insurance companies, regardless of whether they are covering anything, they're passing more and more financial responsibility onto patients. I mean, I actually had you can see I hurt my hand a few months ago, and United Healthcare denied my MRI. And I had paid, $1,600 for the deductible and didn't even think about it, right, for the first MRI. So the second MRI, they said, no, we're not going to do it. Won't pre-authorize it. So I canceled it. Then I called back, and I'm like, how much is it if I paid for it? They're like, oh, it's $1,000. I'm like, oh my God, I'm paying less than if I was an insured patient. So those are the kind of things that I think we're seeing in the commercial space. So basically, watch out. Be on the alert. Lots of things are changing. Yes?
When you said that you do have the opportunity to go through your carrier or to self-pay, I'm hearing conflicting information about that if you're contracted with someone, you have to go. Can you talk on that?
Yes. There actually is a law, and I'd be happy to send that to you afterwards, that does allow the patient to refuse to use insurance for that visit. Now, of course, it gets a little bit sticky because in my case, it was kind of easy because it was an independent imaging center. But if you are talking about a service that is part of your practice, then you have to do some education with patients. patients because they can't then come back if they have surgery and say, oh, that service that I paid for myself a month ago, I now want to send in a claim because I need that to hit my deductible. Right, so there is some education, but I'd be more than happy to send you. There is a federal law that protects patients to allow them to not use their insurance for services. So fascinating. It was passed, I think it was about 6 or 7 years ago. Yeah, happy to share that. I'm all about evidence because it's amazing to me. Like people say, oh, well, you can't really charge patients more than the Medicare rate. Or you can't do this and you can't do that. And you're like, well, where do we hear that from? I feel like sometimes in reimbursement, we kind of pick up things and then we don't ever ask, like, is that actually really true? So definitely delighted to share that law with you. All right, Laura, yeah. One more over here.
Nutrition visits. Can they be billed as telemedicine or it has to be in
Oh,
office?
yeah, medical nutrition therapy, one of my favorites. Let's go back to my little chart. Love my little chart. And so this is actually, each one of these tiles opens up on the CMS website, and you can actually look, let's see where MNT is. And you can actually look at there, and it walks you through. It's just such a great website. I think it may be under DSMT for the, oh, there it is. And yes, it can be done by telemedicine. So really easy, you can click on that and it gives you all the frequency. Great question. Well, I know we're a few minutes over and I know that folks love to get those door prizes, so I'll turn it back over to you.